This program is a presentation of University of California Television. Your support makes UCTV's programming possible. Contribute online at uctv.tv/support. Check out our YouTube original channel, UCTV Prime, at youtube.com/UCTV Prime. Subscribe today to get new programs every week.
Thank you for coming to the second session of the mini med school with dermatology. And just going to put up this slide. So a picture speaks 1,000 words. And with me, as you know, you get the 1,000 words as well. We're talking tonight about atopic dermatitis or eczema. Now, I got into trouble last week when I started asking the audience some questions. But I'm going to do it again. So, does anyone here have children? Quite a few people. Has anyone been a child here themselves? Okay, because last week I got in trouble when I asked a question that I thought I knew the answer to, so that's reassuring. So this is going to be a talk from a pediatric dermatologist. I'm delighted to introduce Kelly Cordora, who's an assistant professor of dermatology and pediatrics. Kelly went to Penn State Medical School and did her residency in dermatology at the University of Virginia, where she was on faculty. And then she came and did a fellowship in pediatric dermatology at UCSF. I'm delighted to say that we managed to coax her to stay at San Francisco. She is a recognized national leader in pediatric dermatology and a very good friend of mine, and I won't waste any more time. I'll hand over to Kelly.
Thank you so much, Kieran. It's a pleasure to be here. And I will tell you that my career did not start as a pediatric dermatologist. As Dr. Leslie just told you, I started as an adult dermatologist, so I get to see the world from both sides, from the young side and the pediatric side and the adult side. And I'm going to talk about atopic dermatitis today, which is also known as eczema. How many of you in the audience have heard this diagnosis? Okay, great. Many, many, many of you. So there's a lot of realities and there's a lot of myths about this diagnosis. This diagnosis is as old as time. People have suffered with atopic dermatitis. And I'll use the terms atopic dermatitis and eczema interchangeably. But I'm really going to try to bring you the perspective of what this disease is. What do we know about the pathophysiology? What do we know about treatments? How do we approach patients? And what are some of the myths and realities? Has anybody seen the TV show Mythbusters? Yeah. One of the guys from Mythbusters actually lives in my neighborhood in San Francisco. And this talk is going to establish facts, but also try to bust some myths. Because there's a lot of misunderstanding and a lot of ignorance. And most of my time in the clinic is spent educating either families or children or parents about this diagnosis and what's true and what's not. And I want to tell you this too. Eczema really, this is eczema or its spectrum, even just common dry skin, affects If not you in this audience, somebody you know. For sure, you all know somebody that has eczema. Maybe you do. Maybe your family members do. Maybe a friend's child does. My talk will be focused on pediatrics, but all of the principles can be used in adults too. So you can use these to take home and tuck into your own back pocket if you have eczema, etc. And I'm hoping that I will answer some of your questions. I've planned on about an hour of lecture time so that I can really talk to you about this in detail, and then that should leave plenty of time for questions. But I want to tell you that I'm a teacher at heart, so I may go longer than that because I may embellish some of the things that I thought I would be concise about. Okay, so what are we going to do tonight? In your syllabus, I talk about what a pediatric dermatologist is, because some of you may not know what we do. And people say, oh, what do you do? Are you bored most of the time? Do kids get skin rashes? Kids get everything adults get. Kids get tumors. Kids get blood vessel anomalies. Kids get autoimmune diseases, which is my area of specialty. Kids get everything that adults get and more. They get genetic syndromes. They get weird birthmarks. So pediatric dermatologists have a lot of business, and there's a shortage of us, actually. So if you know anybody who's going into dermatology, try to get them to specialize in pediatrics because we need more help. So what are we going to do tonight? We're going to talk about atopic dermatitis and go over the things that you can see here. And like I said, I'm going to try to myth bust. I'm going to make sure I tell you the facts first and then the myths, because you may not know the facts, and so the myths won't make much sense to you. So we'll try to go through that in detail. So here's a typical patient in my clinic. This is a 6-year-old boy referred for atopic dermatitis. He was on a very mild treatment regimen consisting of over-the-counter topical hydrocortisone and a food elimination diet because his parents were certain that he had a food allergy that was causing his atopic dermatitis. Now, right away, this should say something to you, right? He looks severe. He has these red patches everywhere. His eyelids are swollen, and he's on a food elimination diet. So could it be food? Could food be doing this when the parents are barely feeding him anything with protein in it? No. It's not, and we'll talk about how food allergy is really not a major factor in atopic dermatitis. So here he comes after skin-directed therapy for a month. He's had different topical treatments, including topical steroids. He's had some non-steroid treatments, and he's had good moisturization. And look how much better he looks after only 4 weeks. Well, then what? Then he came back to my clinic a few months later, and his mom had stopped everything. Why? Because her neighbor said, I don't think those medications are safe. I think you should take him off of those medicines. I've heard that topical steroids can thin your skin. They stunt growth. Look at the stuff that's happening with the baseball players. So this is what happened. Mom stopped. Where did the neighbor get that information? Oh, no. I apologize if anybody here works for Google. I love Google. I live with Google, but I'm going to tell you something about Google. This is your official Google warning. It's your best friend and your worst enemy, all at the same time, right? There's a light side and a dark side of everything, if you believe in the yin and the yang of things. And Google is the same. Anybody can put anything they want on the internet. It's an open forum. It doesn't have to be fact-checked. It doesn't have to be based in research. It doesn't have to be based in reality. Be very careful. I spend more time in my clinics unteaching people things that they learned from Google. So it's hard in medicine. It's a dichotomy because we tell patients, learn everything you can. Take an active role in your own health. Get educated. And then we try to say, quit looking at Google. Quit reading the internet. Don't learn anything. Listen to me. So we try in medicine not to be paternalistic, and Google is great, but you have to really make sure you take that information with a grain of salt. And in this patient's case, it was the wrong thing to do because he came in looking miserable, he was infected, etc. So consider yourself Google warned. So then what happened? We ungoogled him, and we taught the family how to take care of his skin and how to treat children safely. I'm a pediatric dermatologist. I promise you, I don't go home and cook up ways to hurt kids. I just think, what can I put on kids' skin that's going to hurt them and stunt their growth and thin their skin? We don't do this, but there's a lot of myth around treatment, especially topical steroids, and we'll talk about that. How many of you in this room have heard something bad about topical steroids? Yeah, good. Handful of people. Good. We'll talk about that. So what is atopic dermatitis? It's a complex inflammatory skin disease. Intense pruritus. That's the #1 sign. Pruritus means itch. There's skin hyperreactivity. So you touch the skin with wool or some type of synthetic fabric and it itches and it drives the person crazy with itching. And then there's immune dysregulation, not immune deficiency. The immune system's fine. It's just a little bit out of whack. So kids with atopic dermatitis, most of them, don't have immune system problems. Their immune system works fine. They're having immune dysregulation because their skin is the problem, and we'll talk about that more. Atopic dermatitis comes up and goes down, and it gets better and it gets worse, and it gets better and it gets worse, and it affects everybody, but it's more common in kids. The biggest concern is the impact on quality of life. These patients are miserable, and so are their families. They're not sleeping, they're uncomfortable, they're not doing well in school, they're not growing when they're not treated. So, why is that? It's because their skin's drier than normal, it's more sensitive, and I titled my talk tonight, The Itch That Rashes, because many people think that atopic dermatitis is an inflammation in the skin that wouldn't manifest with the patches and changes in the skin that I showed you unless you scratched it and opened the skin and caused more inflammation. And so it used to be called the itch that rashes. And both of that is true. In part, you can get inflammation and some redness of the skin, but a lot of the slides I'm going to show you are completely secondary to people scratching. But it's okay. They're not in trouble. They itch so badly. Itch is the worst human condition. It's worse than pain. So itch is bad. These patients are sensitive to irritants. Their skin thickens when rubbed. It's called lichenification. So they rub it and scratch it so much that it thickens and thickens and thickens and thickens, and then it looks different. It looks like has a leathery texture. And these patients get infected more easily, and I'll tell you why. Let's have a photo tour of atopic dermatitis. Are the pictures showing up okay? Is the lighting okay in the room that you can see everything? This is mild atopic dermatitis. You can see a little bit of skin textural change, a little bit of lightening of the skin. When the skin is inflamed, the pigment-producing cells get stunned. They can't produce as much pigment, one, or they produce more. So you see this inflammatory hypopigmentation, which means lighter skin, or inflammatory hyperpigmentation, which means darker skin. We're going to come back to that in one of the myths about atopic dermatitis. Look at this little baby just with these very, very dry cheeks that just look very taut, very, very taut. And this is an early stage. This child hasn't scratched her skin yet, but it's just very, very inflamed. This is the back of her head. And you notice something. She doesn't have a lot of hair. This is because she's rolling in the crib and trying to move and scratch because her head itches so badly. She's moving around so much, and she's losing her hair in these areas. And you can also see where she's picking herself. This is called excoriation, when you scratch and make the skin raw. Here's another child, a little more advanced. What do you all notice about this slide? What jumps out at you? What part of the... Yeah, the red cheeks, right? The red cheeks are crazy. They're involved. What's not involved? The nose. Isn't it interesting? The nose is not involved in atopic dermatitis. It helps us with diagnosis. It's one of the signs. It's not, we're nobody's sure why. There's a lot of theories. One is that right around the nose, there's more oil glands. This is where you get acne, you know, so there's a lot of oil glands and a lot of secretions making that skin moist. Nobody really understands why the nose is spared in atopic dermatitis, but it's a very helpful indicator of this diagnosis. And now you can see this child's cheeks are really taut, really red, really raw. This is a picture almost exactly like what Dr. Leslie showed, with these changes around the mouth, dry skin, crusting, cracking around the mouth. Very common, and a big factor in children is the drool. You can see the drool. So drool, if you put a piece of food in your mouth and you just let it sit there. How many of you have had a piece of gum in your mouth and you're somewhere where you're not supposed to chew gum, so it's just sitting there? It starts melting, right? Like in an hour, it starts getting real, it starts breaking down. This is saliva. Saliva is meant to break down proteins. It will break down a piece of beef if you have it in your mouth for an hour. What is it doing to the skin? It's breaking it down. So babies who have eczema on their mouth get much, much worse because of the enzymes or the substances in saliva that break down the skin. Here's a child who's even further involved, and you can see, look at the striking swelling around the eye. Swelling is called edema. Look at how swollen these areas are. This child has some allergies. She has allergies to dust and pollens, and it's that's that time of year. A lot of itching around the eyes and around the mouth. And this is the more typical distribution. When cases are mild, they usually happen in the flexures of the arms, in the folds of the body. This is behind the knees. Again, note that lighter skin color, that hypopigmentation. This child's not been treated yet. So this is not from any medication. This is from the disease itself. And this is this area, right? And this is called the antecubital fossa, or the elbow crease, another very, very common area for eczema. This is a little more severe, more red, more inflamed, more advanced. You can see here a patch that's been scratched. Look how the skin lines are accentuated versus here. The normal skin anatomy doesn't have a lot of accentuation, but here it's starting to look leathery from rubbing and scratching. Another example of an untreated patient where we're starting to see the eczema form rings. This is called nummular eczema. Nummular means coin-shaped. Look at how it's starting to aggregate itself into these round areas. Nummular eczema is a really difficult form to treat. And this patient has diffuse eczema everywhere and then round patches, and they tend to be really resistant to treatments. Anybody remember what I just called this, what the medical name is for thickening of the skin that starts looking leathery and dark? It's called lichenification, lichenified, like a lichen on a tree. The lichens look raised and flat top. That's where that word comes from. And what do you think this is from? Yeah, from scratching. You see the patterning here? They're scratching. So this child has predominantly just itch associated with her eczema, and she's just scratching her skin absolutely raw. You can see the lines from the scratching. So a very miserable condition. Another example of just a scratch. So parents will tell me there's blood on the sheets when I go in to wake my baby up in the morning, and that means that we need to do something about this skin. I want to show you darker skin too, because darker skin types, it's a little harder to see the red, but it's definitely there. You can see a patch here where the skin is thickened and pink, and there's some pink around here and in the ears. So all skin types. In darker skinned patients, papules start to form, little bumps. So this is called papular eczema, where you get accentuation. It's not clear why this happens in darker skin, but the eczema will form itself into these little dots, and it gets worse and worse and worse with scratching and rubbing. And look at this on the back of the hands. So you can see this severe papular eczema made much thicker by constant rubbing and scratching. This is the nummular form. So some patients don't have anything except a 50-cent piece patch here and a dime here and a nickel there. That's nummular or coin-shaped eczema. Really itchy, really miserable, very difficult to treat. And this is a child whose nummular eczema is what? What do you think is complicating this? Yeah, infection. This is yellow honey-colored crust. This is called impetiginization. Comes from the word impetigo, which means bacterial infection. Impetiginized eczema means infected eczema, and you can tell because it gets these thick honey-colored crusts. I want to show you an adult. This is a patient who's had eczema her entire life, and now she has it on her neck and her chest. It's mostly red. She's being treated, so hers isn't as thick. And then also a manifestation here is a hive. So patients who have eczema can also have hives or welts on the skin. We're going to start talking about what causes this, and this is a really key picture for you to remember. Look at the butt area. This area is relatively spared. Lots of eczema, lots of eczema, less eczema. This is because the moisture under the diaper is locked in by the diaper, and this is the main way that we treat eczema. We call it soak and seal. So remember this picture, because babies under the diaper are almost never involved with eczema, and it taught us something about this disease, which is that the skin is dehydrated, and areas where the skin is rehydrated and that hydration is locked in does better. And that's how we've been treating eczema for decades. So before you can understand atopic dermatitis, you have to understand the barrier. I'm going to bring you some cutting-edge information, and some of this research was done right here at UCSF in the labs of Peter Elias. The barrier, by definition, is anything built or serving to bar passage, like a railing or a fence. How about the skin as a barrier? It's a novel concept. This concept has only been around in the last decade or so, that the skin is a barrier. Everybody used to think the skin was an inactive organ. It just sat there and covered you. But now we know that the skin is a rich metabolic machinery of the body, and it has a very, very active role. And the concept of the skin as a barrier is really important in understanding atopic dermatitis. And you can think of it like a brick wall. This is my favorite analogy. The skin serves as a permeability barrier, and permeability means the ability of substances to pass through it. The stratum corneum, so here's the brick wall, here's the real picture under the microscope. The stratum corneum is the outermost layer of the skin, and this is where the action happens. This is where the barrier is, that outer stratum corneum. And then these are skin cells. There's different layers of the skin. And the stratum corneum makes up this barrier, and let's look at it in a little more detail, because if you understand this, you understand eczema. The bricks and mortar of atopic dermatitis. So the bricks are the analogy for the bricks is the skin cells, the cells themselves with a protein shell around them, and that's called the cornified cell envelope. It really holds things in, and it allows for mechanical strength. So it's like the skin cells provide the strength in the skin. The mortar, or this stuff that holds the bricks together, consists of 3 different fats. Another name for fat is lipids, and those different lipids are cholesterol, ceramide, and free fatty acid. I put ceramides in yellow here because this is big right now. You're seeing commercials about ceramides all the time. Does this name sound familiar to anybody? No? Okay. Has anybody heard about CeraVe, Restoraderm cream from Cetaphil, any of this? Maybe not. Okay, well, now that I've said this, you're going to see these commercials. So I'll talk to you about what ceramides are. They're the main fat in the skin, in this mortar that keeps essentially good stuff in and bad stuff out. So the barrier is the skin cells and the intercellular lipids. So let's look at that for a minute. These are some of the ceramide-containing products on the market, and some of you may have seen some of these. Triceram, the technology for this one, was developed right here at UCSF. I'm not marketing or telling you to go out and buy any of this stuff. I'm just giving you an example of how the science around this comes to the marketplace to try to help you. So ceramides are big right now. But let's take one step back. You see cholesterol here. So many of you in the room might be thinking, well, if I've had high cholesterol, is my skin better? Or if I have low, it's not related to the level of cholesterol in your body, in your blood system. This is purely a skin cholesterol, which is different. So what we haven't been able to figure out, even though there's been lots of attempts like these products, is really how to replace ceramides in the skin and make them work physiologically. It's unclear if these medicines actually work any better than Vaseline. So that's sort of up for debate, but scientists, the race is on to figure out a way to reincorporate ceramides into eczema skin to fix the barrier. So this is not cool. When your brick wall does this is not good. What happens if your barrier is bad? You start losing water, so the skin gets dehydrated. And then, not only that, as the skin gets dehydrated, it starts separating. And when it separates, what happens? You are living in a petri dish. You are. And you're not getting infected every day if your skin's intact and your immune system is normal. But kids or adults who have eczema are way more likely to get bacterial and viral infections because, look, it's like a playground for microorganisms to get through. So we see lots more viruses and bacteria, and I'll show you pictures of that in kids who have eczema. So why do I show you this picture? If you have really dry skin, your skin can look like a cracked riverbed here, as you can see, or a desert. And this is cutting edge right here. Anybody have any idea why I'm showing you a wrinkly palm? You're not allowed to answer, Kieran. Anybody? Has anybody gone to a dermatologist and they started looking at your hand? My patients think I'm trying to be a palm reader now, and it's crazy because it looks really sort of witchcrafty. But look how liney. Look down at your own palms and look at this palm. Now, if you have eczema, it doesn't count. Your palm may look more like this. But look at the lines here. That's probably remarkably more lines than what you have on your hand. What is this? This is interesting. This has been associated, we call this hyperlinear, lots of lines. This suggests a mutation in a gene called filaggrin. Filaggrin is the magic protein that holds the brick wall together. So recently in Ireland, in the UK, and in the United States, many different researchers sort of at the same time discovered that mutations in filaggrin, or filament aggregating protein, they hold everything together, is altered in atopic dermatitis and a form of common dry skin called ichthyosis. Filaggrin mutations are identified on the skin by hyperlinear palms. So it's a really interesting correlation. They looked at thousands of patients who have known filaggrin mutations genetically and looked at their palms, and this is one of the examples. This is one of my patients. This is a little child, and you can see some hyperlinearity here and here. So we see this all the time. That is new research. This is my favorite picture. A picture's worth 1,000 words, as we already heard. This is eczema before the fingers get to it. And looking at this picture makes me itch. What you're seeing here is you're seeing inflammation. The skin is not supposed to raise up like this and get thick. This is because the cells, the lymphocytes, the T cells on different parts of the immune system are filing into the skin and making blood vessels pour more water and fluids and blood into this area. It's making it red, it's making it raised. The first thing this patient's going to do is start scratching this, because this is miserable. This is like poison oak. And what this is atopic dermatitis. And atopic dermatitis is really two main things: skin barrier dysfunction, I just talked to you about filaggrin mutations, and immune dysregulation. Because when the skin is abnormal, the immune system starts reacting to this abnormal barrier, and it starts a storm of different molecules and proteins that activate. Atopic dermatitis is not caused by these factors, but these factors make it worse. So infection makes it worse, and infection is also more likely in atopic derm. Itch makes it worse. Allergens like pollens and grasses. And food can make eczema worse, but it doesn't cause eczema. What you end up getting is a bunch of different trigger factors that make that inflamed skin go crazy. And I mentioned most of these, but I want to point out stress. We know in medicine that stress doesn't typically cause a lot of problems, but boy, does it aggravate existing problems. And then weather changes. Cold to hot, hot to cold can really make eczema skin get worse. And what I didn't mention here is this itch-scratch cycle. So what happens is you get this inflammation. Was able to get this picture right before this child starts scratching. They start scratching. The scratching makes more inflammation. It's traumatic to the skin. The skin does not like to be attacked with fingers. It starts making more inflammation. That makes more itch, and it's this vicious cycle. When we start talking about how we treat these skin conditions, this is all going to make sense to you. You're going to say, oh, I get it now, because now I understand, versus going to a doctor and them telling you, put these creams on, do this, do that, and you don't know why you're being told to do that. So it's hard to make this, is it hard to make this diagnosis? Not really. Even though there's no lab test, there's no biopsy that you can do that's specific. It's suggestive but not specific, and it can look like a million different things. But it's not that hard to make a diagnosis, because it's sort of a gestalt. And the way we make the diagnosis is that we understand that atopic dermatitis is a syndrome. And a syndrome in medicine is defined by a set of symptoms occurring together. It's not one thing. It's this and this and this makes that. And so atopic dermatitis has been broken down into essential criteria, important criteria, and associated criteria. And essential are itch and a typical skin rash in the typical location. And so 100% of kids with or adults with eczema will itch, and they'll have skin rashes in certain areas. So let's just look at this a little bit. These kids I have 100 more pictures like this that I could show you. Babies often will come in with mittens on because they're scratching so much, they're making the bloody sheets and breaking their skin down. And look at this poor child. When kids are young, they don't know how to scratch, they pinch. So you'll see these kids pinching their skin, and it makes it worse. Look how bad this is. Look how terrible this is. This child needs treatment. You can see the nose is spared, though. Itch-scratch cycle, it is a constant problem. It's something that we really try to address. You're going to get an itch lecture in 2 weeks, if those of you who are signed up for that. Dr. Berger and Dr. Steinhoff. Itch and eczema is really poorly understood, and we don't have great treatments for it. So we sort of have to use multiple treatments to try to get it under control. Eczema is broken up into acute, subacute, and chronic. Acute means new, brand new, it just started. It's red, it's weepy, it's so inflamed that the skin starts leaking water because it's all this inflammation. And inflammation is the blood vessels coming to the surface, opening up and leaking. So they leak all this fluid, and you see these oozy, weepy, my former chairman in Virginia used to say, oozy, weepy, sticking to your clothy. Because the kids would come in and their clothing would stick, and it was severe. So acute, and then the scratching. So these are the most important criteria. And then subacute, this is my friend. He's been a patient of ours for years. We're allowed to show his picture, but as a courtesy, I'm not going to, but he loves knowing that he's in mini medical school. We told him that we're going to show him, and he was like, okay. He's been a patient a long time. This is subacute. Subacute means it's not exactly brand new, but it's not old. So subacute is somewhere in the middle where, there's a little bit of new and a little bit of old. So new areas that are oozy and weepy, and he's just scratched, and some areas that have been there for a long time. This is subacute, and this form is called nummular. Remember, I told you that means coin-shaped. Look at these areas that are that are forming into coins. And look at his left nipple. His left is to your right on the screen, but look at how severe it's absolutely encompassed by the eczema, and that's a very itchy condition. Chronic means it's been there a long time and it's been rubbed and scratched and it's lichenified, so it's thickened and it's dark. And then I want to talk to you for a minute about the distribution. So babies get different distributions than adults. Babies get it on their face, as I showed you in all of those pictures, and they tend to get it around the elbows and the front of and on the knees. Whereas adults, or older kids, tend to get it more in these areas, called the flexures and behind the knees. And then the most common site for adults who have had eczema as kids, does anybody know where the most common site is for adults to get eczema? If you had eczema as a kid, it's the hands. So adults get a lot of hand dermatitis who had eczema as kids. So most eczema is present by 5 years of age, but in almost 100% by age 15. And then there's something called the atopic triad. Atopic means misplaced. And atopic triad is one of three things: asthma, eczema, or allergic rhinitis, or hay fever is the other name for that. So an important feature of eczema is that there's atopy either in the child or in the family. Somebody has one of these things, or multiple, because we know that atopic derm in part is genetically passed. And then xerosis. This is the medical term for extremely dry skin, xerosis. And then there's many associated features like dermatographism. This translates into writing on the skin. So you can write, you can see right here, this person wrote itch. When you write, the skin gets so inflamed, or when you scratch, that you make these lines. Keratosis pilaris. These are these aggravating dry bumps. Some of you in the audience may have them up on the upper parts of your arms, on your cheeks. They're plugged skin cells, essentially, plugged hair follicles. And this is really common in eczema. This is sort of an extreme form of dry skin. And then there's something called Denny-Morgan folds, or allergic shiners. Well, you'll see a patient with these lines under the eyes and this swelling. And this is from tissue edema, and this suggests that somebody has allergies. So the pollens come out, the grasses come out, and they get all of this blood vessel swelling here. And Drs. Denny and Morgan came up with these names, so they're called Denny-Morgan folds, and allergic shiners because it looks like you have black and blue eyes. And then lots of changes around the ears. You can see this honey-colored crust, eyelid swelling, as I've shown you, and then again, this picture of the drool around the mouth, very common locations for eczema in kids. Just to show you a couple of different changes, in darker skin, we see the perifollicular accentuation, so accentuation of this eczema around the hair follicle, so it looks like little bumps. Lichenification, the thickened dark skin, and then this extreme dryness. So this is a little baby who has a bad eczema. And then, of course, it's incumbent upon us to make sure we're not misdiagnosing this. Is it scabies? Have we missed that? Is it psoriasis or other diagnoses that can look like or mimic atopic dermatitis? So you need to make sure that you're not making a quick diagnosis, that you're really considering this and many other diagnoses that can look like atopic dermatitis. So once you've done that, you can be pretty sure that you've nailed the diagnosis. Now, the epidemiology of this diagnosis, epidemiology means who gets it, how old are they, what part of the population. That's what epidemiology means. And the trend is that we're seeing it more in Western countries and developed countries. And there's a threefold increase in industrialized nations. But eczema is extremely rare in farming communities and agricultural nations. Does anybody know why? Or have an idea or a thought? Why are urban dwellers getting it? Why are wealthier people getting it, or their kids?
Less natural microbes and things.
Beautiful. That's exactly right. What do you see on the backpacks of every child getting onto the school bus, hanging on the back of it? A hand sanitizer, right? Everybody, we're crazed with this whole thing. So there's something called the hygiene hypothesis. And the hygiene hypothesis says that allergic diseases can be prevented or counteracted by exposure to bacteria in the environment. And so if you have infections in the early ages, it balances your immune system. So your immune system gets some exposure to bugs and it builds up that part. You get some exposure to allergens, it builds up that part. What happens with the hygiene hypothesis is we're so clean, We can eat off of our floors. We have hand hygiene. Every soap is antibacterial. We're not letting our children get exposed to bacteria that makes their immune system more balanced. And excuse this is a little medical here, but I want to show you that Th1 and Th2, these are different arms of the immune system. And the Th1 arm, simplistically, is the infection-fighting arm. Th2 arm is sort of the allergy, reactivity, hypersensitivity arm. If you're not getting any bacteria, then this arm is just sitting there. And this arm is going crazy. So the allergic paradigm is sort of higher. And so this is the hygiene hypothesis. So people think that we're too clean and we're creating a problem with our immune system and allowing more eczema. And this is really beautiful and elegant science that has been brought forth in the past 15 years. So what happened, and that's just one hypothesis. There's many, and we don't understand what exactly causes eczema, but that's a thought. I don't want you to go home and start feeding your kids dirt or anything, but in general, it is important that we get, that we get dirty. We play outside. We do these types of normal kid activities. The atopic march means that if you start out with eczema, now your skin barrier is broken down, and allergens and bugs and other things can get in and make you allergic. So the atopic march means you start with eczema, and you march, and then you get asthma, and then your skin keeps going, and you get what I have here I think is respiratory allergies, which is hay fever, etc. So there is some push lately to treat eczema aggressively in babies. An article was just published in Journal of Allergy and Clinical Immunology showing that kids who had untreated eczema were much more likely to get asthma and hay fever than kids whose barrier was treated, because it's thought that you're getting some sensitization through the skin. Kids who have allergies, eczema, and asthma tend to have much more severe disease and tend to hold on to their eczema their entire life, versus those who have more mild eczema tend to outgrow it in the older years, and half will go on to develop hay fever. So this is sort of what can happen. Let's talk about food allergy, because this is a really a big area in atopic dermatitis where there's misunderstanding. There's really no food or foods that cause atopic dermatitis. And so that means that eliminating certain foods won't clear your eczema. So even if you have allergy tests and you're told that you're allergic to A, B, and C, your eczema may be worsened by that, but it won't necessarily be eliminated if you stop eating those foods. And food allergy is tricky. Clinical correlation means here's what the test shows. What happens in real life? So to be careful not to be over-dependent on tests. I think sometimes we order tests when we don't know what else to do. So it's really important to have clinical correlation, which means if you have a paper that tells you you're allergic to shrimp, fish, chicken, and soy, just today you got those tests back and you say, gee, well, gosh, I had shrimp, chicken, soy, I eat those foods all the time. That means it's a false positive. So a true food allergy, you'll have a reaction within an hour to 2 of ingesting that substance. You'll get hives. Your skin will get really itchy. This is within an hour or so. These are not the allergies that cause chronic ongoing eczema. So it's really important to understand that negative tests are the most helpful. A positive test is only true half of the time. And this is just allergy testing. This isn't all of medicine. There's certain tests. Positive test means you've been sensitized, means your body has become sensitized to that, but it doesn't mean that you'll manifest the allergy. So I may be sensitized to shrimp, but I eat shrimp all the time. That means my body has found a way to counteract it and I'm not really allergic. If you get a negative test, that's 98% certain you're not allergic to that. So I see reams and reams and reams of allergy tests all the time in my patients, and the parents are confused, and the kids come in on elimination diets and they still have bad eczema. So we understand over time that many of these are false positives, and it's more important to rule out allergies and much easier. This is skin testing, if nobody has ever seen this. This is a child. We used to have a combined atopic dermatology allergy dermatology clinic, and our nurse Glenna would do this. So in children what the new recommendations, and there's new guidelines just hot off the presses in 2011, who do we test for allergies in the world of eczema? 2 reasons. One is if standard therapies fail. So we're going to talk about treatment here in a minute. If the treatments fail and the eczema is still really severe, it's reasonable to look for allergies. Number 2, in patients who known triggers exist. So if you say, every time I eat a strawberry, I get hives all over my chest, that's a known documented trigger, and we would test you to confirm that. This is a child who, these are all the different allergens that we suspected in him, and then the nurse will mark the numbers and then do a little puncture. You know, it's uncomfortable, but it's not terrible. They're not happy immediately, but it's not torture. And then afterwards, you see if they develop a hive, and if they develop a hive, that means they have a positive test. I mentioned the role of infection. So staph infections and herpes simplex virus are the two most common infections people with eczema get. Staph is everywhere. So staph is on many of our skin. If we cultured all of you for staph, a significant subset of you would just be growing staph. That means you're colonized. It doesn't mean you're infected. It's just hanging out with you. In kids who have eczema or adults, your skin barrier is impaired so that staph gets in and it makes more inflammation. So it secretes these things called super antigens, which really just non-specifically activate the immune system and cause itch and scratch and itch and scratch. Herpes simplex virus, 80 to 90% of us in this room have herpes simplex virus type 1 in our mouths. So what happens? A baby has a face full of eczema. Grandma gives the baby a kiss very innocently. She was carrying HSV1. It's the virus that causes cold sore. So anybody who has a cold sore has had HSV1 if it's that type of cold sore. You kiss the baby can't block that HSV1, it gets in through the infected skin and they get something called eczema herpeticum, which is this herpes simplex virus type 1 rash everywhere. And let me show you some pictures. It can be very terrible. This is impetiginized or eczema that has impetigo on top of it. And you can see that honey-colored crust. That honey-colored crust is infection. Here, this child also has honey-colored crust, but there are these punched out dots, which almost looks like you took a little 3-hole punch into the skin. And this is what herpes virus does. It punches ulcers in the skin. So when you see this, you know that there's herpes simplex virus. And in fact, we tested, and this child had both. So eczema, uncontrolled eczema is very risky, very risky. This is another child who has impetigo everywhere. Look at all the honey-colored crust just everywhere. These parents were nervous. They didn't want to use treatments. I don't want to treat my baby. I don't want to put anything on my skin, on my baby's skin. And I understand that. But when you see things like this, you understand the rationale of treatment. Another example, terrible. Another, family understandably nervous, understandably have been Googled. They've read, and all the treatments are dangerous. You shouldn't do anything for the skin, and this is how their baby came in. It's really amazing. I'm humbled every day by seeing kids who come in like this, because these are good, well-meaning parents. I mean, they want to do the right thing for their child. And you see like this, and it's a real disconnect, because we want to do the right thing for our children and for ourselves. So we don't want to use medicines that we interpret as being dangerous, yet we'll have this situation happening. So it's really interesting what happens to the psyche when medicine gets involved. So what is this? I just told you what does this. Yeah, this is herpes. And same thing here. You can see this is all over the body. So this kid's eczema was so bad that the herpes just spread like wildfire. Another example of these herpes punched out lesions all over the hands. This is treatable, easily treatable. We have good medicines by mouth and good medicines by IV. So it's easy to, none of these kids did poorly. Everybody turns around and does fine, but this can be quite devastating. This is a patient of mine, a 16-year-old boy who has really severe eczema. This is, bullous means blistering. So he had a staph infection that caused blistering. So all of these, he has eczema that was pretty well controlled, but all of a sudden he got a staph infection, and some staph secrete a toxin that makes blisters in the skin, and he came in with these widespread blisters. And this is just because his skin barrier could not fight this off. So let's transition to management now. Let's talk about this. Now you understand, you're armed with knowledge, you've got the bricks and mortar down, you understand what infections can do, etc. How do we prevent this, or how do we control this disease? How do we go from this to this? I'll tell you right now that there's a lot of preconceived notions. I just said parents, but this could be you, this could be me. I still practice around wives' tales that my mom told me when I was 10. Like, if you go outside without a hat and it's cold, you'll get an ear infection. Totally untrue, but I still wear a hat when I go outside because I don't want to get an ear infection. So there's a lot of things embedded in our bodies from what was passed on. So what parents are thinking is, oh my gosh, we did something wrong. It was something I did during pregnancy. What are we doing? It's got to be something he's eating. Maybe it's the laundry detergent. Baths are bad. I'm not giving him any baths because I heard that they're bad. Topical steroids scare us. We don't want to use them. We just want this gone. Just make it go away. This is uncomfortable for everybody. So this is the notion that this is what we're up against when these kids come in. And what we really know is this is nobody's fault. It can't be prevented. We still, in 2012, March, we don't know what causes atopic dermatitis. I showed you slides about what we know it does to the immune system, but we don't really know what the real trigger is. We know it's not the laundry detergent. The cause is not a food, usually. It can make it worse, as I said, but it's not causing it. Baths are fine, and I'm going to talk to you about how you take care of your skin. And topical steroids are safe when used correctly. So let's go through some of this. One thing is for sure, nobody in a household with a patient who has eczema is sleeping. Does anybody know any families or your own where there was a child with eczema? Nobody is sleeping. Nobody is happy in that family because these kids are miserable at night. During the day, the itch can be distracted by school or play. At night is when itching really, really gets bad. We have treatments. We don't have a cure yet. This is really important for you to know. There are no natural products, there are no holistic therapies, there are no herbal remedies that will consistently take care of this. I am not holding anything back for my patients. It's really, if there was something natural or holistic that could cure it or make a significant dent in it, I would be the first one to recommend it. But we don't know anything that works well. And at the end, there may be questions around different medicines. I won't say any more than this, but I don't have these in my talk because there aren't any that are proven. And what's really important is that this is tried because people deem these treatments to be safer. But natural doesn't mean safe. And there was just an article today in our dermatology literature that some creams coming from overseas have mercury in them. And patients putting these lotions on their skin are getting mercury toxicity, which can cause seizures and damage the kidneys. So these are all unregulated. So creams, natural therapies, herbal therapies can have severe consequences. So you have to be really careful around this. So here's the big picture, is that dermatitis, atopic dermatitis is not just a skin disease. One of the big problems is right here, sleep disorder and behavioral issues. If the patients aren't sleeping, if you have eczema and you're not sleeping well, you're not performing the best at your job the next day, you're not concentrating, you may not get the promotion, you may miss days because you're so miserable or have infections. And children we see are having a lot of behavioral issues because they're itchy, they can't control themselves in school, so the teacher thinks they're being bad or acting out, and it's a vicious cycle. So this is really a situation that impacts the entire family, and there's a lot of stress and anxiety on the part of the parents around this. There's lots of different therapies we have. It comes down to emollients, which is the general term for moisturizers. There's topical steroids. We have new non-steroid therapies. We use antibiotics and antivirals if there's infections that are detected. We use antihistamines to help control the itch. If we can find an irritant allergen, there's no question that if you're allergic to trees and the trees are blooming and you live in the Central Valley and you have eczema, your eczema is going to flare. So we look for those things and try to avoid what we can. Phototherapy is great. I'm not standing here telling you to get in a tanning booth, but we use medical grade light. Ultraviolet B is an immunosuppressant, so it locally inhibits the immune system in the skin and helps with the itch and the inflammation of eczema. And then in really bad cases, we have to suppress the immune system. So we never want it to get to that. We always want to use topical therapies. There is no topical therapy in the world that is going to have close to a side effect as an immunosuppressive therapy where you're taking everything down versus just using the skin therapy. So let's go through some of the rationale around these treatments and whether or not they're safe. So the goals in many are to prevent infection, and we want to maintain growth and development. There have been many studies done that kids who have eczema fail to thrive. They don't grow as well, they don't develop as well, physically and cognitively. So they may not be able to develop because they're distracted. And then I talked to you about the atopic march, how there's been recent data that eczema can lead to asthma. And then we want to, of course, optimize quality of life. That's always a goal in medicine. And if your doctor isn't thinking about your quality of life, then they should be. So in the next several slides, I'm going to talk to you about which is worse, the disease or its treatment. And I'm going to let you be the judge at the end. So we have all of these children who need to get treated from either localized disease to severe disease, or in adults as well. Like I said, the treatment concepts are the same, whether you're 2 or 92. Education is so important. So my clinics always run behind. It's my biggest criticism. You know, Dr. Cordova runs behind, I waited an hour. But I'm going to tell you, when you leave, you have been educated. I like to take the time. It's really hard to, in a 15-minute visit, examine the kid, take a whole history, and then educate the parents. And I think where we go wrong sometimes in medicine is we don't take the time to explain to you the rationale of why we're treating you, what is going on, why am I telling you to bathe more, et cetera. And I think that's really important. So education is really important, and you should expect it from your physician. You deserve to get it. It may not all be in one visit, but sometimes I reschedule patients and say, why don't you just come back and we'll talk about this for 15 minutes, but let's treat at this visit. So different ways to get educated. And then let's talk about basic skin care and topical medication. So here is the main 6 things. If everybody who comes through our clinics, the rotating pediatricians, residents, interns, other doctors, medical students, I teach them these 6 things, and these are found in all basic dermatology information, is that this is the approach. So let's go through these. And as we go through these, we'll bust some myths too. So one is to repair the barrier. Now you know what the barrier is. Look at this barrier. This is not a good barrier. This barrier is really broken down. What we need to do is rehydrate the skin. So we know the skin is dehydrated, so a bath, a soak in a tub, just plain water will bring moisture into the skin. You soak the skin 10 or 15 minutes, and then you seal that moisture in by putting an ointment on. We like ointments and oils best. Ointments are petrolatum based. There is no basis in fact that petrolatum is dangerous. It doesn't even penetrate the stratum corneum, that top layer of dead skin cells. Petrolatum just sits on the skin. It's the perfect barrier. It just sits there. So if you've bathed and you've returned water to the skin, now you put a layer of Vaseline on or petrolatum, that water sits in there and helps your skin to rehydrate. It does not get absorbed. And so petrolatum is not toxic, but that's a myth out there, and I hear that from a lot of parents. You want to look for white petrolatum. It's the most purified form. So that's my favorite, and it's the cheapest. And then there's others. There's other moisturizer. These are my favorites. Ceramides I mentioned because this is sort of the rage right now. It's questionable whether the ceramide-based creams work better than petrolatum, but some patients swear by them, and so I recommend all of them. And you kind of have to use what you want, what works for you. So anybody who says that water avoidance is in is not up to date with their information. Water avoidance is out. Hydration is in. This is the wave. In the past, many, many, many decades, patients were told, don't take a bath, only bathe 2 times a week, stay away from water. When you bathe, your temperature goes up, and when your temperature goes up, your blood vessels get big because that's hot. So the only way you have to decrease your core body temperature is for your blood vessels to open up and you evaporate moisture, and that cools your body. Well, that's really bad if you're an eczema patient. So a bath will make your blood vessels get big, but if you put a heavy ointment on after the bath, any evaporation that happens can't be lost to the environment. It stays in your skin. So if you can only bathe or shower and not put cream on, then you shouldn't bathe or shower. But if you have the time to what we call soak and seal, or soak and smear, or soak and grease, however you can remember it, then you'll do yourself a favor. And you want to put those moisturizers on immediately after the bath. Try to stick with non-soap cleansers because non-soap cleansers are not as drying. Non-soap cleansers, these are the best. All 3 of these. The one that starts with a D that you're all thinking, that one's actually bad. Who knows what the D one is? Dove actually has a high pH, and so Dove, although it's a synthetic detergent, what we call a syndet, still has a high pH and is a little stripping to the skin. So if you have mild skin or normal skin, Dove is great. I have Dove at home. If you have eczema, not a good cleanser. Okay, so this guy, right? A bath. Look, okay, let's test your learning. What do you notice about this picture that makes the point that I'm trying to make about soak and seal? Yeah, exactly. It's nature's perfect soak and seal. So there you go. So we try to get the parents to do that with the rest of the skin. And it's important to recognize to rehydrate the skin because water is not the enemy. Bubble bath is the enemy. So you want to avoid bubble baths because there's harsh chemicals in bubble baths. So this is a terrible picture, but it reminds me to tell you that bubble baths are not good. Plain water, lukewarm, not hot, not cold. This is the enemy. This is what we need to prevent, right? So use that bath, and we encourage. I wanted to put this in here because many of you might be asking this. Laundry detergent doesn't seem to make a big difference. This is taken right from our handout that I give all of my patients. As long as you're rinsing the clothes well, a second rinse is okay. Some fabric softener strips can be a little irritating, so you can try to avoid them and use liquids. And then wools and synthetic clothing can be very irritating and can make your itch worse. So these are common, just helpful tips. Let's talk about topical steroids. I'm going to tell you that for the last 45 years, they've been first-line therapy. Does anybody know what the adrenal gland is? The adrenal gland is a little gland that sits on top of your kidneys, and it makes hormones. And one of the hormones is cortisol. Cortisol, no you. We all need cortisol. It's the perfect anti-inflammatory, and it kind of keeps your metabolism going correctly. Topical steroids are essentially cortisol made in a lab somewhere. So they're an anti-inflammatory that have been made to sit on the skin, and that's why they're called cortisone. So topical corticosteroids get a lot of myths around them. They're not the ones that athletes use to build muscle, and they're not the same as when you take it internally, which has a number of different potential side effects. Topical corticosteroids are anti-inflammatories. You have to have a doctor who understands the right strength to use in the right body surface, because when you can get in trouble, what's the number one fear that you have of topical steroids? Somebody shout something out that they've heard. Yes, thank you. It thins the skin. If you use a really potent topical steroid in a very thin area, like the eyelids, like the genital skin, the inside of the arm, over a prolonged period of time, that steroid will thin the skin. It really will, because the blood vessels get constricted. It's not feeding the skin as well, and that skin will thin out. If you use the right potency, your doctor will know high, medium, low. There's 7 different potency categories. So we have all, it's like that going to a hamburger bar and you can put all these different condiments on your burger. We have all these different steroids to use. So it's really important that the agent that's selected and how long you use it is based on how bad the eczema is. Where is it on the body? Where is it distributed? How old are you? What vehicle are you using? Vehicle means, is it given to you in an ointment, a cream, a lotion, an oil? Vehicle's really important. It's like, did you come to this lecture in your Porsche or in your 13-year-old Subaru like I did? The Subaru, not the Porsche. That's the vehicle. Vehicles are as important in medicine as they are to you for transportation. It's how we deliver medicines into the skin, and vehicle matters. So ointments are good, but ointments can make a steroid more potent. So your doctor should know and understand. The goal is to control the disease, taper the topical steroid, and then withdraw it, and then use it again as necessary. For 45 years, we've used these medications, and in the right hands by a trained doctor, we just don't see side effects. The side effects we see are when patients come in from non-dermatology trained folks that are prescribing medicines and not really supervising its use. So the average medical student, the average resident, like family practice or internal medicine, gets 2 weeks of dermatology if they're lucky. Dermatology is a 4-year residency. So imagine, this is when people get in trouble. They're not sure, and they just prescribe something, and then you're not under supervision. And this is where all of the myths have come around topical steroids. It's a beautiful medicine and safe when used appropriately. So we spend a lot of time talking about steroid phobia. You can get thinning of the skin, which leads to stretch marks. Thinning of the skin in and of itself is not dangerous, but it can lead to disfiguring stretch marks. Systemic absorption and the problems related to that can be an issue if you use really highly potent steroids on the whole body for many, many months. So in a baby, we use low potencies. You can use it on the whole baby, but you have to adjust the potency. So you should make sure to understand that these are safe medicines. They do not cause Addisonian crisis, which is a situation where you take steroids by mouth. So you can get absorption, and we're aware of that, but they just have to be used appropriately. So I just want to make the point to you is that as long as they're being used adjunctively within the framework of what we're talking about, this 6-step care plan, you're going to be fine. There's no way you're going to thin the skin, right? This lichenified skin is 700 times thicker than it should be. So there's just no way that this skin's going to get thinned with a steroid. Now, I showed him again to make the point that you have to use different potencies in different locations. So I would use something different on the face than I would on the arms and the legs, which are thicker sites, etc. We really get more nervous that you're not going to use the medicines or that our patients aren't going to use them, because then we see what I showed you. All of those pictures of undertreated children, that's our concern. We don't treat these children, they get the infections, they don't thrive, they have a poor quality of life. Now, here's one of the pitfalls. Here's a myth bust. We see this a lot. So another risk that you can read on topical steroid labels is that it will make the skin light. I told you before about inflammation related to, or pigment changes related to inflammation. This is a child who has pityriasis alba, which is scaly white skin. This is just eczema untreated. So this is not related to a steroid at all. This is a form of eczema. Pityriasis means scale and alba means white. So when the skin's inflamed, it gets light. This is a kid who had really bad eczema, and now hers is improved, but the melanocytes, the pigment-producing cells, are still stunned, so they're not producing enough pigment. This is how this risk got embedded in package inserts, that it will lighten your skin. So be aware. Now, where you can see vitiligo or lightening of the skin from steroids is joint injections. So I've seen lots and lots and lots of patients with white patches where they've had a joint injection for arthritis. That's temporary, that goes away. But steroids injected into joints will turn the skin white. Okay, lest you think all I want to talk about is topical steroids, no, no, no. There's many, many different things to use. How many of you guys have heard about Protopic or Elidel? Has anybody heard about these? These are called TIMs, topical calcineurin inhibitors, and they're topical immunomodulators that had some play for a while. They're non-steroidal, so they don't have any of the steroid risks, but they're pretty mild, so they work great for eyelids, face, folds, and groin. So we have options to use on this thin skin where side effects from steroids might be more likely. So we have this beautiful class of medications. Has anybody heard about these guys like Mimix, Atopiclair, any of this? These are new ceramide-containing creams, and these are prescriptions. Very, very, very expensive, and I question whether they work any better than Vaseline. So we're still back to, basic petrolatum, Cetaphil, Eucerin. So some of these new kids on the block just don't have enough ability to treat eczema, because what they do is they moisturize, but they don't treat inflammation. But these non-steroid agents, again, are really good for locations like the face, these thin areas in the around the eyes and in the elbow folds. So controlling the itch, I told you before that 100% of kids will itch. We use antihistamines. You're going to hear in 2 weeks if you come to the itch lecture, we don't really understand what causes itch and eczema, and it's probably not histamine. Because we know when we give non-sedating antihistamines like Zyrtec, Claritin, you've all heard of those, it doesn't really help, but it helps if you have allergies. So these antihistamines help allergy symptoms, which can kind of flare your eczema. So we use non-sedating antihistamines if you have pollen allergies. The reason we use sedating antihistamines in children is to stop this from happening. So we try to stop the itch-scratch cycle, make them a little more sedated at night, let them get some sleep so they're not digging their skin and creating that inflammation. So that's why we use antihistamines to control the itch. Look at this. This is just horrendous. This is a family I met at the University of Virginia. 2 brothers, there are 5 kids. They all looked like this. What do you notice about this picture? Check this out. Yeah, it's because he has socks and shoes on, so he can't scratch it. He can't get to it. So he is a complete mess. His brother couldn't even stop itching for me to take the picture. So itch is so pervasive in eczema. We don't have great understanding, but we try to use the skin-directed therapy. So when we use the topical steroids and topical immune response modifiers, etc., that helps to take the inflammation and the itch out of the skin. This is what happens in really severe cases of itch, where you get the lines and the thickness. So I mentioned this to you, that you can have sleep disorders. Probably 80% of the kids who have eczema have sleep disorders because they're so itchy that they can't sleep well, and this creates this cycle, as I told you before. So, okay, I made that point to you. They all itch. And so the third rationale here is looking for and treating infection. We want to treat early, we want to treat aggressively, and we want to treat bacteria if we culture it with tests, and viruses like herpes simplex if we culture it. Have any of you guys heard about bleach baths? Bleach baths are something that we're using now in the past 5-8 years. Dilute bleach baths, making the bathtub like a swimming pool. A cap full of bleach to a gallon of water, or a quarter a cup of bleach to a foot of water, makes a very dilute bath, and it kills staph. So we're finding ways to not have to keep giving patients antibiotics all the time, all of these oral antibiotics, which can create resistance and create public health problems. So you may hear somebody saying, oh, my doctor told me to take a bleach bath, and it sounds horrific, like it's going to burn your skin off. It won't. It's just like getting into a swimming pool. Very, very nice method to keep the burden of staph down. Another example of just staph involvement that we can treat. Now, this is a child who has eczema herpeticum, and you can see these punched out erosions, and I've already really told you about this, but this condition is very severe. This is what we look to prevent by doing good skin care. This is a teenager of mine who had it around his eyes, all over his face, and it's a very well recognized complication of atopic dermatitis. If it gets into the eye, you can have permanent visual loss, so it can scar the cornea. So this is a medical emergency. The reason I put this up here is, does anybody know what varicella is? Yeah, it's chickenpox. So this gets misdiagnosed for chickenpox all the time. We don't see a lot of chickenpox anymore because of the vaccination, but Dr. Kaposi, who's known for Kaposi sarcoma, developed this term called varicella-form eruption because they used to always think that this was chickenpox. And the chickenpox virus is a herpes virus in the large group. So all of the herpes viruses make these punched-out lesions. So this often gets mistaken even today for chickenpox. Now you know. Okay, one of the pitfalls is depending on oral antibiotics all the time instead of using skin-directed therapy in the first place. So you can prevent these infections and prevent having to use all of this. And then one of the final points I want to make is being careful that in medicine, we're not over-evaluating and over-diagnosing and over-treating food allergies at the expense of using some skincare. Because I've shown you, almost all of the pictures that I've shown you in this presentation are patients who were on food elimination diets because it was thought that the food was a cause. And I mentioned this already to you, that we really have to be careful who we're testing and who we're not because we get false information. The children are already failing to thrive, and then we throw a modified diet at them and they can't thrive. It's really important to educate families, and as I mentioned, you owe it. Your doctor owes it to you to educate you about what's going on. One of the big important things in eczema is lifestyle modification, trying to avoid triggers. So if there's lots of stuffed animals in the room and the child has been found to be allergic to dust, removing the stuffed animals. There's something called shared sleeping where, okay, imagine this. You have a job, you have a child, your child has eczema. Your child comes and you have to get up at 7 o'clock in the morning to get to your job, to get your kid off to school. At 11, your child jumps into your bed. They're so miserable. So you spend the next hour scratching your child's back, trying to help the itching because they're so miserable. They finally fall asleep. You finally fall asleep. Then they wake up itching again in this big cycle. So now there's a child in the bed. There's a disrupted relationship between the parents. There's a disrupted sleep cycle for everybody. Everybody's miserable. Everybody's tired. Everybody's not performing well. This is a big problem. So we talk to families about shared sleeping and try to eliminate this and try to direct skincare appropriately to try to eliminate some of this issue on quality of life. It's a really vicious cycle. And then I think that everybody deserves to be told about risks and benefits of different treatments, because unless you're told that, you can't make an informed decision. And that's really important. And then I mentioned to you about frequent visits. So if you're not understanding the rationale behind everything, reschedule an appointment and say, okay, I'll work on this, but let me come back and ask you more questions. And then explaining alternative therapies. For example, this is the big question I was getting in the past couple of years, probiotics. This is hot right now. And the definition of a probiotic is a non-pathogenic organism when ingested exerts a positive influence on the health or physiology of the host. Is that pretty vague or what? I mean, that's vague. And I wanted to say this again, as I said in the beginning, natural doesn't mean safe. Probiotics are an interesting scenario. Probiotics are bacteria meant to restore sort of the normal bacterial balance in your body. But the problem with probiotics right now is that they're very unregulated. So one capsule of a certain probiotic may have 500 million units of X bacteria. Another capsule in another bottle may have something completely different. It's unclear how many of them stay alive. So how many of them are really bioavailable? Are you taking a pill of dead bacteria? So it's completely unregulated, and it's a really controversial area right now. We at UCSF are not recommending probiotics, in dermatology, are not recommending probiotics because we just don't have data. If patients take herbals, natural supplements, etc., and they're doing fine, I don't discourage them. But I will tell you, there's been many studies about Chinese herbal therapies and Chinese natural creams. Many of them have been looked at in labs and determined to have high-potency topical steroids in them. So I'm always, which is fine. I love topical steroids. We use them all the time. But when you don't know that that's what you're getting, that's when we see problems. That's when it's dangerous. So I'm not against herbals. I'm not against natural therapies or Chinese medicine. There's a role for it. And I like the term complementary because I think Western-trained doctors and other doctors should work together and try to answer some of the questions, because I think that there is a role, but it's important that we as patients and we as doctors don't sort of blindly follow something because it's natural. As I told you, there's been toxicity from mercury poisoning recently because of a natural cream. So be careful around this and just make sure you're educated. Finally, maintaining the skin integrity. You don't always have to treat your skin. You want to keep it treated by getting it clear, and then we try to step down the regimens. Don't use the steroids anymore when the skin is flat and no longer itches. If you start flaring, just treat in that area, etc. So we really ask families also to keep a trigger diary so that you know every time you step into your friend's house who has a cat, you seem to react, you may take an antihistamine before you go over, etc. So let's bring it home by going through a quick case, which is this 4-year-old boy who has really diffuse infected eczema. His parents are very fearful. They're cautious. They've refused topical steroids in the past because of concerns. There's co-sleeping. The baby's losing weight. He's miserable, and he's just very unhealthy. So he comes in, and he is just head to toe. He's infected. He's got staph around different areas, and every part of his body is involved. Very upsetting situation that we see too common. So how do we get him to go here to here? The way we move this child from looking like this into looking much better is, I'm going to give you just an example. To bring everything home for you is repairing the skin barrier means you getting some anti-inflammatory, putting out the fire. You've got to use something, whether it's a topical steroid or a topical other type of immune modulator. Remember the soak and seal. Remember the bathtub, you putting on an ointment afterwards. Controlling the itch. Really, a nighttime antihistamine made a huge difference for this child because he stopped digging so much and wasn't as inflamed in the morning. He absolutely had infection, so we cultured him. He had bacteria growing. We gave him an appropriate antibiotic. We don't like to use antibiotics commonly in atopic dermatitis because most of these kids carry infection, carry bacteria, but when they're actively infected versus just being colonized, you've really got to treat them with an antibiotic. And then we took a lot of time to educate the parents and ask them to follow up. So you write out the care plan. There's no way that you can possibly leave a visit and you've been told to do 8 things and you walk out and by the time you're at the car trying to find your keys out of your purse, you just think, I have no idea what I'm supposed to do. So ask your doctor, or you as in many med school graduates, write care plans and give literature, give written information about what you just talked about. And then maintenance, really following the patients up and not sending them out on their own with 10 different creams and not knowing what to do without a step-down regimen. That's when kids get in trouble. That's when adults get in trouble. That's when we see side effects. When we write prescriptions and think that's the end of the visit. It really needs to be an ongoing relationship. And you can do the same with a small child. So we see kids from, as I said, 2 to 92, and the treatment regimens are the same. I threw a couple of names of different things in here. You may be familiar. This is a really low-potency steroid, generic, called Desinide. There's a nice fluocinolone. This is an oil. It's really nice to go on large areas. It spreads really nicely. It's very mild. It's one step above what you can get over the counter. Lots of moisturizer, some sedating antihistamine at night, or also in kids, they can take it every 6 hours if they're young kids and they're not in school to try to help to get the kids under control. And it's temporary. None of this is permanent. It's all temporary to get them through the flare. And then they're just using moisturizer. So it's not like it's a lifetime sentence of treatment. It's sort of a waxing and waning treatment as is necessary based on the skin disease. So what do we do when they're really bad and none of this works? Well, we try to determine, are the patients doing what we think? Are they doing what we're asking them to do? Are they adhering to the regimen? We culture and make sure there's not infection. Then I'll consider allergy testing. Remember, one of the times you treat or you test is when the skin isn't reacting to the prescribed regimen. Phototherapy is a great therapy. It's a nice therapy to get inflammation under control. And then sometimes, in my practice, a lot of the times, we have to end up using medicines. You may have heard of some of these: cyclosporin, azathioprine, methotrexate. These are big medicines. So I would way rather have a patient on topical creams than to have to put them on that. But not every patient, it's not like every one of these kids I've cured. We can't cure any of them. Remember, we can only make them comfortable. So if that doesn't work, we have to move to more important medicines that help minimize the immune reaction. Systemic steroids. Have you heard of prednisone? Has anybody heard of that medicine? That's changed medicine. People's lives have been saved by prednisone. Don't get me wrong. This is a medicine that is indispensable in the field of medicine, but it also has a lot of side effects, and you have to be careful. In kids with eczema, interestingly, If you give a child or an adult prednisone, it controls the inflammation really temporarily, but then what happens is it flares again. So as soon as that prednisone's out of the body, that eczema comes back and it's worse, and it's harder to treat. So when you use steroids or are given steroids, that can really reset the baseline level of severity of your eczema much higher. Now don't stop taking your prednisone if you're on it for other reasons, because I'm saying that, but I'm saying in eczema, we try to avoid it unless we're using it as a bridge. Many of the children I've showed you in this presentation we've had to put into the hospital. You know, you can't send a child home who's raw from head to toe, so sometimes they need steroids as we know we're going to give them more aggressive care and treat their skin. But as a general rule, we try to avoid them. And it takes a village. Many, many, many collaborations I have, and all of us with primary care, allergy, infectious disease, and other specialists that really help to manage these complicated patients. And so as we come to the end of the presentation here and have time for questions, I want to ask you, what do you think is worse, the disease or the treatment? I'm hoping that I created a compelling case to say that the treatments are safe when they're used appropriately, and you really can feel comfortable if you're using them or your friends are using them, etc. And so these are my two boys that are so sweet, great kids. I miss them, but they were the two who sort of got me really interested in atopic dermatitis back in Virginia. And so with these guys, I will stop and take questions. Yes?
Do you find that with children with atopic dermatitis, that as they mature, if they are adhering to a regimen and a plan, as they mature into adults, is there a diminishing effect of the dermatitis on the person?
Oh yeah, do they outgrow it? Yeah. So there's a couple of factors that predict them outgrowing it, and one is how severe it was when it started and how young they were when they got it. So many of the children I showed you that were infants can be anticipated to have a bad course. You know, when they're that severe and they're starting that early, and particularly if they've already been diagnosed with asthma, this predicts a more genetically pervasive, severe disease that probably will stick with them, but not usually at that level of severity. Most patients, not all, but the large majority of patients definitely will improve, because remember I showed you that teeter-totter with the Th2? The immune system matures and it starts to eventually get more balanced. And when that Th2 maturity happens and the Th1 arm starts coming up, that's usually around adolescence or late childhood. We start seeing the eczema get way better, much easier to manage. But there are, I have teenagers and I have adults who are on systemic immunosuppressives, they're doing phototherapy, so there's definitely 10 or 15% of patients who will not get much better. All of these kids are going to have dry skin. You know, they're going to be the kids who need to put moisturizer on, they have dry skin. What degree just depends on how bad they were when they were a child. Some of these kids who looked horrible, a couple of them actually are completely clear, and I haven't seen them for years. It was just a matter of a strong hit in the beginning, a misunderstanding on the part of parents, not getting appropriate treatments, and then treating them. One thing I'd like to say to you is that inflammation begets inflammation. So the more inflamed your skin is, the more inflammatory molecules that are recruited to come in. So if you have some inflammation, it just keeps sometimes accelerating. And so it's really helpful to treat, because you're not just putting a Band-Aid on the skin rash. I've already told you we can't cure it, but you're also controlling that inflammation, which might slow down the immune system from continuing to kind of rev up. So that's an excellent question. Most do better with age, to simplify my answer. Yeah, I'll have your question then over here. The question was about some of the herbal therapies and supplements that may have dangerous chemicals. The problem is that these molecules are not under FDA scrutiny like medications are. So a medication, they're obligated to list all of the ingredients, active and inactive. Also, the FDA requires that if you call, and you call the company, and I've done this because I want to know what the pH is, so I know if I want to recommend a cream. If you call that company, they are required to tell you anything you want to know about the molecule, where it's made, what plant, under what circumstances, etc. Herbal therapies are not under the FDA scrutiny, and neither are certain devices. So some of the creams I put up there are now called devices, which is a way to circumvent the FDA regulation. instead of being a medication, they're considered a device, so that they're just a moisturizing cream, and they're also not under the scrutiny. So the way we find out about herbal therapies, et cetera, and what they have in them is we have to send them to chemists. And chemists can take the cream, of course, and extract it and tell you what the component ingredients, but they are under no responsibility to tell you that. And so it's hard as a doctor to tell a patient, because hey, if acupuncture, massage, things help you, I am all for it. I believe in a holistic approach. But it's really hard to advocate these things when I can't tell you what I'm advocating for you. So that's the risk. That's the big risk. Young lady, yeah.
2 questions. What is the mechanism of steroids that makes them so effective?
Oh, great question.
And I forgot the second question.
Okay, all right, you'll think about it. We can come back to that. It's a great question. It would have taken me 5 slides to show you the mechanism. So steroids are the ultimate immunosuppressants. So essentially they inhibit T cells. T cells are the parts of the immune system that are inflammatory. They react, they're your friends, they fight infections, and they also can react against you. So topical or oral steroids will suppress T cells. They can suppress the molecules that T cells secrete. They can suppress B cells. So they non-selectively suppress. They're sort of they just suppress different parts of the immune system. And so when you're taking, for example, patients who take oral steroids, which I already told you actually that topical steroids and oral steroids, they're all derived from a natural molecule called cortisone. So if you use a topical steroid for too long, the risk is you might interfere with the cortisol production from your own adrenal. So the biggest risk that I didn't get into was if you're putting a really potent steroid on a little baby, for example, who has a lot of body surface area, so that's a lot of medicine to get into that little body, it can make the adrenal gland say, hey, I don't need to make any cortisol right now because I already have some in my system. The body is such a beautiful machine. It works on feedback loops. So if there's too much of this, it will just shut down the production until you need it. So steroids can shut down the production of the normal cortisol because they're a mimic molecule. And this is when you can get into trouble with oral steroids, where you can't take a lot of them and then just stop, because the body will go into a crisis and say, I need that. So there's something called a taper. So if any of you have had any experience with prednisone, your doctor will taper it. You'll be on a dose and then you'll slowly go down, so your body recognizes, hey, I'm not making as much, I don't have as much cortisol, and it revs it up. So steroids have many, many, many beneficial activities, but also many, many, many harmful activities. But essentially, they're non-specific immunosuppressives.
I remembered my second.
Okay, go for it.
How soon do patients start to actually feel relief from the itching and everything once they start treatment?
Oh, it's a great question. It depends on the level of severity, but usually within a few days. By the way, if we admit a patient to the hospital, severe eczema, they essentially get soak and seal. They get a very expensive, very organized soak and seal. So when we put children in the hospital, or adults for that matter, we do what we call wet wraps. We soak them in a tub or a shower for 15 minutes or so. We lube them up with an anti-inflammatory, whatever the creams are that we're using, and ointments. And then we put wet wraps or wet pajamas on them. And what the moisture does is it drives that medicine in, and it drives more moisture into the skin. And then we put a dry pair on top. So if any of you have severe dry skin, I'll just give you, this is just a little pearl. I do this a couple times a week. Soak your hands, soak your feet, whatever is dry on you, your whole body. As soon as you get out of the shower or the tub, immediately put a thick layer of moisture. If your hands are really dry, if you're in an occupation where you're washing a lot or dry, once you're done with everything for the night, soak your hands in water for about 10 minutes. Tons of Vaseline. If you have eczema, you can use a little cortisone mixed in there, and then put gloves on your hands. And then you've now effectively done soak and seal. If eczema is that severe, we do that, and they feel relief within a few hours. It's pretty amazing that as soon as you bring that inflammation down, rehydrate the skin, that itch-scratch cycle starts to downregulate itself. So pretty quickly. Yeah, you, and then over here.
I've heard from people in medical school, like in the process of learning about this, that dandruff can be like a manifestation of eczema, or like can be confused with eczema, but I only saw one of your pictures had like a scalp.
Yeah.
So that, like, what is the tendency of eczema to just show up just on the scalp?
Rare. So that's a great question, because a really, really, really beautiful article was just written about what is dandruff. In babies or in adults, it's called seborrheic dermatitis. And have any of you heard the term cradle cap? Cradle cap is, is dandruff essentially in babies. It's that waxy yellow, orange scale on the scalp. It's thought now, and that's caused by oil secretion. So if a mom is breastfeeding a baby, her hormones are passing through, and the oil glands react to hormones. This is why teenagers get acne and not, babies get acne because mom's hormones activate the oil glands. The oil glands secrete, clog the pores, and you get a little acne when you're a baby. Mom stops breastfeeding. There is no activity whatsoever for acne until teenagers, when you start going through puberty and you start secreting hormones that make the oil glands secrete. This is the same thing with seborrhea or dandruff. So cradle cap is thought to be a response to, it's sort of complicated, but in babies it's supposed to be a response to breastfeeding and oil secretion in a young child. Also, children are born sort of hyperandrogenic, so they have lots of hormones in their body when they're born. Their adrenals are big, so babies have really active hormones when they're born, whether or not they're being breastfed. There's a yeast that lives in the skin that causes seborrhea. It's a normal yeast. It lives, and when the oil glands are secreting, the yeast eat that and makes scaly skin. Scaly, flaky scalp, and that's called cradle cap seborrheic dermatitis. Now there's a big movement. Most people think that bad seborrheic dermatitis in children is actually eczema. So if the child has bad seborrhea, usually it will eventuate into being eczema. And so that's sort of a complicated story that's being figured out right now. But in terms of cradle cap or seborrheic dermatitis in an adult or in an older child, it's almost always eczema. If they're not an infant or they haven't hit puberty, it's always eczema, because you just don't get cradle cap unless you can make oil. So I don't know. I may have given too complex of an answer for your question. Did I answer your question? I'm not sure I did.
Yeah, but then when it's adults, because adults can still have eczema.
Okay, yeah. So in an adult, it's hard. Because adults can have, it's hard to tell. I mean, you really can't tell. And even if you do a skin biopsy, which you wouldn't do, because it's such a benign condition, it would look the same under the microscope for the most part. So in adults, the only way to tell in some ways is the distribution. So if it's only in the scalp, it can be eczema or dandruff. If it's also scaly in the eyebrows, on the sides of the nose, in the middle of the chest, or in the upper middle part of the back, that's dandruff. Because this is where the yeast lives, this is where the oiliest parts of the body are. That's called the seborrheic distribution. That's where the oil is, nose, central chest, forehead. And behind the ears. So if there's scale behind the ears or anywhere off of the scalp, it's probably dandruff. Whereas eczema doesn't, I showed you all those pictures, eczema doesn't like to go here, etc. So there are ways that you can tease it out if you absolutely had to, but the truth of the matter is the treatments completely overlap. So I don't find myself engaging in that. If they have an atopic history, they've had asthma or allergies, etc., then they might be more likely to have eczema. But it's sort of an age-old question, and there's no criteria to tell the difference. Thank you so much. I really appreciated it.